Yeah, okay. Yeah. Thanks so much, everyone, for joining. Welcome to the Leong Center's Trainee Hub. My name is Priscilla Medeiros. I'm the Knowledge Mobilization and Community Engagement Specialist at the Center, as well as your moderator for today and every day in terms of the Trainee Hub. So thank you so much for coming. If you haven't helped yourself already to coffee, tea, food, please do so in the back. For those joining online, I will be keeping an eye on the chat for your questions as they stream through to ensure that they're answered by our presenters for today. So I'm really excited about today's session for a couple of reasons. One being that I've invited my colleague, Danielle, to come and speak about her work at Target Kids, which is closely tied to our work at the Leong Center. The Target Kids is co-led by one of our intervention chairs, which is Dr. Catherine Bergen. So very excited to have this team come and present. We've also have a couple of snippets of video from some of the PACT members who will be sharing their perspectives, insights, and experiences of being involved in a parent advisory group. We're also joined by one of those members today, which I'm very excited about. So you certainly will have the opportunity to pose some questions that you may have in relation to the work that you're engaging with or planning for that involves parents and families. So without ado, I'm going to pass things over to Danielle so she can do a quick round of introductions to those on her team that are here today and to get our presentation started. Thank you very much for joining us today.
Thank you, Priscilla. Thank you all for having us. We're excited to talk about our work with patient engagement. And if you on the call, if you need me to speak up or anything, just get that message in the chat so I know to either increase volume or adjust accordingly. So as mentioned, I'm coming to you today from Target Kids, which is the Applied Research Group for Kids. What we're going to discuss today is our experience with developing what we call the Parent and Clinician Team, but effectively, for your understanding, a parent advisory group that helps inform our research and helps us to advocate for the participants and families that are involved in our study. So today we're going to give you an overview of our Parent and Clinician Team. You'll hear viewpoints from 3 of our parents who are actively involved, and then we'll join for open discussion. So you got an introduction, you saw the poster, you got an introduction about myself, and Priscilla gave you an overview. So we'll know what I'm going to do is introduce our parents who contributed to this work. So Carrie Stewart has proudly belonged to Target Kids since she became a mother in 2014. For years, she and her 2 children have participated in the Target Kids cohort in numerous studies. She joined the PACT in 2020. And being able to connect in real time live with other parents and everyone involved has helped to broaden a fuller understanding of the goals and importance of each research project. You'll hear from Carrie via video today. Maria Zachariah Cho is an experienced health information professional communicator and project manager driven to translate knowledge and deliver information to various stakeholders. She has been a PACT member since 2018, where she's had the opportunity to contribute to various research projects. Maria has a passion to advocate to advance patient involvement work, to support research and ensure patients' perspectives are considered in all aspects of care. She's married with 2 children, enjoys playing board games, cycling, hiking, and traveling. What you'll hear from Maria via video again today. In person, live and in the flesh, we have Maureen Colford, who has been with Target Kids' journey for many years. She joined both as a participant since 2008, and she joined as a parent advisor in 2018. She and her family have contributed to our research with both data and various insights. As a full-time parent to her 2 sons and daughter, Maureen is an anchor and foundation for her family. She is no stranger to patient advocacy, working not only with Target Kids, but with countless groups over the years, including, but not limited to, the WHO, Pregnancy and Infant Loss, Bell Let's Talk, and the Ministry of Health to lend her voice, expertise, and insights to improve research, policy, and health systems. She's worked on various campaigns to increase awareness for pneumonia vaccination and helped to secure funding to explore research methods for teaching math. Maureen is a passionate human rights advocate, and we're excited to have her here today so you can hear directly about the work that she's been involved in and hear about her passion and working with kids to improve the health of others. So how did we get started? We take you back a little ways to 2008, where Target Kids was founded and emerging out of a vision of 3 investigators. It's a practice-based research network for children. We're focused on prevention, and the uniqueness about our group is we are an active and ongoing longitudinal cohort. We have not stopped recruitment, and we continue to recruit families from ages 0 to 5, and we follow them until 17.9 years, so 18 completed years. With that type of trajectory and the work that we're doing, it's been invaluable for us to have patient partners involved because we are walking through these families for such a long journey and continue to increase and enhance our work. The goals of Target Kids is to maximize the value of children through children's data through linkages across sectors, to learn about children's health and well-being as they grow and develop, to implement new knowledge to help children reach their full potential, to build a state-of-the-art style cohort through primary care-based practices, and to test promising preventative interventions to raise healthy children. You'll hear some about those studies and work from the voices from our parents and how they've seen that work translate as we go on. As stated, we are a practice-based network. So we have practices based in cities across the GTA, and we continue to grow and look at opportunities to enhance our representation in our network. The way we've operated is we embed research assistance into these practices to engage and to connect directly with the families, to recruit and build relationships and foster that trust beyond the clinician patient relationship, but also within research. So we have over 10 group practices, over 60 clinicians in practice are engaged with us, and continue to grow our network of staff, students, and trainees. So from 2008, we fast forward to 2018, where after 10 years of working in the field, we've started to hear and understand that, we needed to embrace and work through the challenges that we face in research and the different opportunities we have for growth by bringing in parent voices. We're dedicated to engaging and building that relationship with families from the outset, which is why our research assistants work with the families right directly in clinic. But we hadn't embraced bringing in parents and families who had been on the journey with us to bring in their voices to our considerations for our future goals. So in 2018, we established the Parent and Clinician Team with the goal to actively engage parents and families throughout the research process. Currently, our PACT is over 10 members, and we have active participation from most of them, which is wonderful. We value the work that they do in interpreting and the use of our findings. They help us set research priorities, they help inform study design, and they help evaluate some of our outcomes so that we can ensure that the work that we're doing is focused on what's interesting and applicable and relevant for patients and families. But it's not an easy road to develop patient advisory. There are lots of things and challenges that you'll face, especially when we started back in 2008. The landscape wasn't paved for research, for patient engagement. It was something that wasn't actively talked about, funded, or encouraged. So we had to pave the way. We even noticed that the landscape of literature out there in terms of involvement and expertise was also lacking. So some of the challenges we face and continue to navigate are funding support. We know that granting bodies continue to need some more encouragement in understanding the value of having patient voicing. So we've sought out different opportunities and are encouraged to see that more opportunities are coming to support that landscape, but it's not necessarily where it needs to be to continue to support ongoing and active patient engagement in all research. So we have to be intentional and deliberate in how we budget, how we approach, and how we sell the involvement and active benefits of having parents involved in our study. Retention. Parents and people who are involved in the research study have different priorities. So making sure that we're involved in connecting with those families, not only from the cohort, but also from our parent advisory, is important to understanding their needs, the flexibility that they may require, and being understanding of the challenges that they may face. Diversity and representation. We have limitations by just being a growing network and a growing cohort. So we want to make sure that we're bringing in voices from different perspectives across not only gender, race, sociodemographics, but geography, upbringing, and other things. So we continue to talk about it so that we're reflective of making intentional decisions so that we enhance our representation and diversity. Engaging child participants. With the growing nature of our cohort, we haven't had participants old enough to actually continue to contribute yet, and we're excited to be at the point that we actually are and have developed not only our parent advisory, but an accompanying youth advisory. I mean, in 2008, when we started, the kids were only from 0 to 5, so getting their involvement and their engagement, it's had to come from the voice of the parent, which is important. If anyone has sat with a room of 5-year-olds, getting them to, targetly answer a question is challenging. But as they grow, we want to grow with them and hear what they've learned and also value the experience that they may have had from being in the cohort for so long. So watching and walking with parents and getting the children involved is very important to us. Institutional buy-in. we were pioneering a little bit at the time, and it was not every group had established a parent advisory back then. So we're still looking at encouraging that advocacy and that prioritizing it across the institutions to know that it's valuable, it's necessary, and it's needed. Thankfully and wonderfully at Sick Kids and the Leong Center, we have people like Knowledge Mobilization Specialist Priscilla or Dr. Francine Buchanan, who is continually being those voices for patient research. But admittedly, those are recent. Those are not established from the longitude of this organization. So we're still in the growing years of this landscape, but excited that we can go along in that journey. And momentum. Making sure that we're keeping the families engaged and wanting to continue to contribute, and also our work and prioritizing it, making sure that we're bringing them alongside of the journey, not getting too distracted by the growing pace of research is a challenge. So we're making sure that we continue to anchor and root all of our activities and circling back to the PACT so that's not an afterthought, so they continue to feel the momentum to move things forward is important. So what is our parent and clinician team? We have a mix. We had some parents of our families, we had the clinicians who were doing the research, and we had the research teams together. And this tripartisan group is who will make up our parent and clinician team. When we bring together the families for discussion and for input and insight, it's working across these three networks so that the parent voice is not just heard amongst themselves or amongst people that we put in front of them, but that it reports back to those who are executing the research on the ground or the clinicians who are turning the research into practice. It's very important it's very important that the parents also see the clinicians who are doing the research and the research teams to get to know them, so that there's not just faces in the research assistants and clinic that they may have met or their clinic doctors, but all people who are involved in touching, supporting, and translating their data. As I previously mentioned, some of the landscape was lacking in when we first established it. So we tried to add and inform the work that we've been doing by adding publications, which I'll get to a little later. But wanted to pull out one of the quotes that we have from our parents and families that we included in our publication. That when parents are involved in the studies from the beginning of the research process, we perceive a higher degree of credibility in the findings and encourage others to trust health research over less credible information found elsewhere, online or word of mouth. This demonstrates the value in what we've built in bringing parents to the forefront into our research and these collaborations. And they see it being involved in the studies and in the research that's been translated moving forward. We're going to stop hearing from me and we'll share a video from one of our PACT members, Carrie. He's going to share her considerations and why she joined the PACT.
And when I consider why I joined becoming a member of the PACT, and how I joined as a parent within Target Kids with my children involved in studies for a few years, then I was approached by one of the nurses at my clinic who belongs to Target Kids and told me about the PACT. And that was intriguing to me so that I could further potentially involve myself in the studies that I was participating in and that my kids were participating in. I didn't fully know what the PACT exactly would involve for myself. So I joined with then the full support of the entire PACT team from the side of the clinicians. So the physicians and the researchers and the managers and everybody involved to foster this PACT were available by email, by phone call. They were present at every meeting. Of course, at the time it was virtual, but they were there and very welcoming to any questions, any opinions, and my opinions were definitely considered. And it was by joining regular meetings over time that would help explain what the process was, help give us a sense of what research even means, the different grants that go forward and how we can support as parents in the community to give grant letters. And as I became a member for a little bit longer within the PACT, I developed a stronger understanding and a sense of how I can help and contribute. And all along the way, getting to meet the clinician team in person at different events and also virtually in our meetings really gave me a solid identity and sense that I belong to this research group.
Now I'll ask Maureen to share her experience.
So, right, am I?
Nope, you can. There's no place like that microphone.
Okay. So I'm Maureen Holford. I joined PACT. I was approached by a woman, I'm trying to think, 2008? Yeah, 2008. I had just had my son, George, and I have 2 older children. And same pediatrician had seen us the whole time. And they're a bit older, there's a bit of a gap. Life doesn't always happen the way you plan it, it just happened. So I had been through a whole lot with them, and I think she sort of looked at me and thought, the pediatrician at the time, and thought, hey, I bet we get great data out of them. Anyway, Lori, I've met Lori, who is the research assistant. I want to say nurse. She's not
She's a research assistant, still with us, still in the clinic. Yeah.
Anyway, and she was very friendly, and there were 5 million forms to fill out. Anyway, and then the blood test, which, anyway, one of the things I had discovered over the years is that with my many, many medical adventures, is that just because you look at someone, how they look, yes, it can tell you a lot in terms of diagnosis, but for example, I didn't realize until I signed on to my chart when it first started, and somehow they had a whole bunch of all my past blood test results out there. I had had chronic low-level anemia for 15 years. Like, oh, somebody saw it was a bit low and told me, take more, take more, take more. And fine. And then after a while, I stopped and up, down there. But it was always just that kind of low, whatever. It's not something anybody would see on, like, just looking at one set of results. It had to be seen as a long trend line. So I had learned, yeah, blood tests are a big deal. They matter. Even when you think, oh, healthy baby, bouncing along. So, yeah, I was really happy when they introduced the pain patch thing so that it froze, and then there was no reaction. Anyway, yeah, I joined it, but I had also joined, just interesting, you were talking about the history and how it was so new. It was new at sick kids. But I know people who were NICU parents who had been trying to get patient participation and parent participation more put in, and God love them, but sometimes the things with sick kids, it's like they're seeing parents at the worst times of their lives, and the patients, they don't always see you healthy when you go back. Like being a family doctor, you will see things. And our previous pediatrician, I was so sad she retired, because she told me, she said, you know, I used to see these kids in the NICU and they have a brain bleed. And, oh my God, it was a catastrophe and there were so many problems. And then they came in and they're 18 and they're going off to university and they're just mouthing off like normal and everything is fine. And it completely changed her perspective, because maybe they had been making a lot of assumptions about how things might turn out. It isn't until you take a long turn out. Anyway, and Women's College had done a parent and patient and family. They'll have the plaque on the wall. We have a patient involvement, whatever it was, committee thing, but that doesn't necessarily mean they did it. Women's College had, and they actually sent me down to Golden, Colorado in 2000 to learn all about evidence-based medicine. Evidence-based medicine, family-centered care and maternity, family-centered maternity care, everything. And so we come back, and I think the government started trying to shut down Women's College, so that didn't do that. That was not the most successful. It was kind of rocky, but we had done a lot of good things in the meantime. But yeah, so I wanted to get involved with another one. Okay, this is a slightly different perspective than just maternity care or early. Here I am. And
Okay.
yeah, come back.
So echoing what I said before, the landscape when we started wasn't still established. Maureen just shared her trajectory and journey to getting into patient engagement and seeing ups and lows and baby steps in growing and moving forward. It takes a lot, but institutional buy-in and other areas, outside factors are really important to help build that success. So we're happy that we've been able to forward a path forward, but there's still a long way to go.
And
So how does the PACT work with us? Beyond encouraging families to come and sit with us and walk alongside the journey, there are practical ways and real ways that they get involved and want to show and outline what those are. So the value in which we hold the PACT's involvement is in all areas of the research life cycle. We want them engaged in pre-planning, when we're identifying and determining questions with researchers, assessing the applicability of our research in the landscape and to families and the relatability, providing letters of support and grant reviews when we're looking to apply for funding. We want them involved in the data collection, providing suggestions on what tools and maybe the materials that we're or instruments that we're using. The recommendation on recruiting when we're thinking about launching a new study. What are the considerations that if we're approaching this family or this age group, what do we need to think of for that family to relate to them? And what are the considerations to engaging with participants? Are there barriers? Are there limitations? Are there opportunities for us to translate this research or these opportunities in a different way that will land with those particular families? Beyond looking at these participants and opportunities to collect data, having the PACT involved with us, we're able to look at the whole family dynamic and shift our focus in research. Sometimes we get lost in just wanting to gather the data. And I don't mean us personally, I mean researchers as a whole. The landscape gets lost and we're just trying to get to the results. But before you get to the results, you have to get to the family. So making sure that the patient voice is incorporated and echoed and listened to is invaluable. We encourage their viewpoints in the data analysis to add the parent perspective on the data found and to apply the results to a real world context, taking it out of the statistician world, taking out of the publication world, taking out of that scientific and academia world, and what does it mean to a parent and family based on what we've found? And knowledge translation, like what we're doing today, having parents come and speak and bring and share their experiences to translate it to different audiences, working on parent perspectives, sharing parent perspectives at conferences, reviewing our public materials. Did we make this land for you? Is it a good brochure? Is it a good poster? Will this encourage people? Are taking us out of our own narrow focus lens on this is what we want to achieve? Can we change it to make sure that it's also relatable and harnessing the positive feedback we want from families? Also looking at social media because of the day and age that we live in and other blogs or other stories. How can we bring forth the work that's being done from various viewpoints? We also outline the different types of tasks and their time commitment, appreciating that parents and families have other things going on. They have full-time jobs, they have children to mind, they have priorities, they have homes, they have caregiving responsibilities, they have their own pushes and pulls. So when we're asking for framing the support that we're looking for, we kind of talk about it and frame it in, okay, what are you looking at? If you're looking to write a blog post, we're not leaving them without guidance, we're helping to support them so that the ask is not too daunting of them on their task. And same with supporting grant applications. We do our best to work with them to share so that they feel empowered and understand what they're reading, the different aspects and different components, but also work on, okay, it's about this estimate. If we're providing questionnaire feedbacks, we say 2 hours, but we know in Target Kids, our questionnaires are quite daunting, so it can be longer than that. If other parents were here, they would have laughed as well. But we want to help frame the ask and what we're looking for. We've had them work on welcome packages, we've had them work on communications with students and other knowledge translation. But we also talk about it and think about it. We're bringing this task to them. Is this a task that's going to take their entire week, their month, their year, or is it a task that we can develop into bite-sized formats to appreciate the time that they need to contribute in their own lives? And we highly recognize that their value and expertise is not being done without recognition in terms of compensation. The work that they're providing and the work that they're doing is helping to fuel our research in ways that we can't put a dollar value on, or we can't put an individual value on. But we do recognize there are limitations in research funding, which we know, but prioritizing it and embedding it into the research proposal helps to offer some support to the families for their time commitment, for their insight, for the value that they bring. So we built a structure that outlines it based on the type of role and the level of commitment that they're able to provide. So can you attend a few meetings? Are you available by email? Are you providing advice and feedback for decision making? Are you a listener, a co-thinker, or advisor? Meaning that you're working and coming alongside us in meetings. You're talking through and providing, you might be asked to provide a focus group or given some documents to review in advance. And we've looked around the landscape and evaluated that at 500 per year, but also recognizing that these rates were established at one period and we all know the economy that we're in. So we need to make sure that you're not staying stagnant if you're developing a compensation structure. You also have to reflect and look at where you are today and what are the considerations for those people's time. So looking to review and revise and consider the opportunities for increased funding. And that also means going back to your fundings landscape. Looking at other levels in the structure, are they committing to a committee? So they're doing more regular meetings with a different group or providing more specified insights. Are they partnering alongside the research team to provide letters of support and implementing feedbacks and actively involved in multiple time points along the way in the continuum? That's noted at a different level. Are you working in a way that's more business oriented and governing in the governing structures? Are you now identifying and leading specific activities, identifying opportunities, seeking out those ways to pioneer and for us to follow? And that we tie that role to something that's more senior and again for a more ample compensation. It's not to say that any individual role here is valued is valued differently so much as it's the level of commitment and contribution. So a person who can only contribute to a few meetings versus someone who can lead and initiate activities, they're equally valued in terms of the roles, in terms of their expertise, in terms of what they can contribute. We just know that it takes more time. So we attribute the value differently. But there's different ways of considering different structures. We also just used a benchmark that we saw in the landscape and in the literature to help evaluate how we wanted to approach it. So beyond the practical aspects of how we developed the group, how do we stay connected? Because it's, again, these are not just one and done initiatives. We can't send an email and not follow up. We can't have a meeting and not stay connected. We need to make sure that we're fostering those relationships. And how do we continue to build trust and ongoing support? So when we continue to develop our own acumen and our own skill sets, we developed a orientation package for new PACT members and continue to revise it accordingly. There's a list of resources for parents and families if they had not done patient training or family-oriented research, listing different courses that they could take to help them get more familiar in what it's like to be a parent partner. We offer updates and a sense of ownership for the PACT. So when we first started, and this has evolved, we had its own dedicated PACT-specific newsletter where we were communicating to the PACT in isolation. It was what we started at, and we thought it was a good way to kind of build in that identity, but we've evolved. We also developed terms of reference for the PACT, for them to have buy-in, and what are they accountable for in being involved in this work? What do we want to have them showcase, and what are our responsibilities back to them? We now have integrated the PACT, instead of it being developing individualized resources, more integrated into the broader target kids infrastructure. So we showcase the PACT and the parent partners on our website. They have their own page where their own research resources are highlighted, along with the outputs and the accountabilities that we hold on the research priorities that they've set. We've integrated them into the newsletter. When looking at our types of communications, there was no need for it to be siloed. So it's important. So now they can see more of the research that's coming out, and they're represented. We also encourage them to be part of the voice coming out of the newsletter. We rotate our intros from different people and encourage PACT members to include an intro in our various issues. To build their identity, we also built and developed unique branding. And we're talking, it happens. Sorry. Leveraging the identifying an umbrella model for target kids, the PACT has its own logo that is co-branded and supported. It's got its own slide deck, as you can see what I'm using today. We've got its own letterhead for their own letters of support. They have an email, like all of these individual components that help to build in the business operations of this group beyond just being an advisory. They have their own entities, their own supports, their own reflection of the work that they're doing, and it can be seen across the work that we're doing. So when investigators come to us for letters of support, they get a PACT branded letter. If we're doing a PACT presentation to the PACT or other groups, they have their own slide deck. It's built into the Target Kids framework using complementary colors, but their own individualized design. So what have we accomplished working together as a group? The PACT is established, and we also published on this 10 identified research priorities for Target Kids to guide our research and inform our work. So our first 5 are effective strategies for screening and prevention of mental health problems. Number 2 is interventions to increase physical activity in children. 3, the impact of daycare attendance on child health and development. 4, effective interventions for obesity prevention in young children. 5, interventions to promote social skill development. 6, the impact of parental stress on children. 7, effective methods for screening and developmental delay in children. 8, effective strategies for behavior management in children. 9, nutritional factors that affect child behavior. And our top 10, appropriate amount of screen time for children. This prioritization exercise was done in collaboration. It took several iterations and months to work through this with the PACT to figure out the ranking, the total, and hone in on what these areas of priority and interest are for families. We developed this in 2017. Approximately, even before the PACT had been formally established, there was work being done to actually help inform our research and where we were going. And last year, we did a review to assess, since the timing of our publications and these priorities were launched, where have we landed? How have we supported our research against these top 10 priorities? So priority 1, we've had 5 publications, and the impact has yielded 342 citations, primarily looking at school, the COVID-19 pandemic, and parental stress. Priority 2, which was the interventions to increase physical activity in children, we have 6 publications, which has yielded 45 citations, using information on screen use and sleep, and stuff on cardiometabolic risk. Priority 3, we had the impact of daycare attendance on child development. We've had 2 publications that have yielded 14 citations, primarily looking at outdoor play and school. Priority 4, the effective interventions for obesity prevention, has yielded 28 publications with 313 citations. With honing in on topics on socioeconomic status and nutrition. Priority 5 were in interventions to promote social skill development, have had 5 publications yielding 338 citations, primarily looking at COVID-19 and impacts and attendance in school. Priority 6, and with the impact of parental stress, has yielded 15 publications with 354 citations. Naturally, COVID-19 and parental stress, those went hand in hand. For priority 7, the effective methods for screening developmental delay in children. We had 15 publications with 159 citations, specifically looking at oral health and maternal health. For our number 8 priority on effective strategies for behavior management in children, we have 3 publications, particularly focused on temperament and COVID-19. For priority 9, we have nutritional factors that affect child behavior. We have 36 publications that have yielded 376 citations, looking at topics ranging from dental needs, school, and food insecurity. And lastly, our last top 10 priority was the amount of screen time that is appropriate for children. We had 8 publications that have yielded 160 citations, looking at COVID-19, speech development, and school success. The range of our publications and their impact demonstrate our ways of how we hold ourselves accountable to the areas of research that are important and have been denoted by our parents and families. We continue to guide and inform the work that we do, aligning to these priorities. And when we did the exercise last year, we did a refresh to check in. Are these priorities still what you rank? We asked the families, what are your top 3? Just to make sure that we're still tracking alongside what they deem as important for our research and for the cohort and relevant for them. So now you'll meet Maria and hear what it's been like for her to be involved in the PACT.
My name is Maria, and I have been a member of the Target Kids Parent and Clinician Team, or the PACT as we call it, since 2018. And during that time, I've had the opportunity to contribute to the development and review of grant applications, provide letters of support for applications. I've also had the opportunity to contribute to various research projects related to screen time, COVID-19 screening, assessment of children's mental health during the COVID lockdown, and a healthy steps to school success in primary school children, and the expansion of Target Kids to other communities. So really a wide variety of projects and opportunities. Through my time with the PACT, I've also contributed to the development of the new website, the children's resource booklet that was created to support children of Target Kids clinics, and other material created to support current and future Target Kids families. My experience contributing to research has been very exciting and very fulfilling as a parent representative. Families like myself have had the opportunity to connect with the researchers who are collecting data from either some of the practice sites or having the opportunity to be involved in the research projects. Really provides space for individuals like myself and families to share our experiences, share our perspectives, and have our voices reach the researchers and the clinician team. And I believe that engaging with more families really strengthens the work and the value that Target Kids is undertaking for families and communities. As part of my experience with the research projects, I've had the opportunity to be involved in the development of the research proposals right from the very beginning. So shaping what the project was going to be like, how we were going to reach school-age children within the Toronto school boards, understanding what the aim and the goals of the projects were and helping to refine those goals, and the opportunity to work side by side with the clinicians and the researchers to shape the work, shape the project, and what we were getting out of, what kind of data we were getting out of the project. So having planning meetings, being able to review and provide content to the grants, being able to review the submissions before they were submitted, and being able to provide letters of support as well were very exciting. And in one of the projects, I was working with another parent and patient partner, so that was very exciting as well. For some of the COVID-19, both the mental health in children during the lockdown and the screening, I had the opportunity to help shape the surveys that were being sent out to target kids' families. So I was able to participate in the review of the draft survey, provide additional feedback to questions, how they were formed, what type of wording was being used, how families might interpret or misinterpret some of that information and some of the answers that were being provided for multiple choice. So really being able to contribute to how the language was presented, what type of information was there, and simplify some of the language for the audience. So really trying to provide lived experience in terms of how individuals might interpret that information or missing information. So survey responses that weren't initially provided as part of the multiple choice, so was able to share feedback in terms of what was missing and what should be added. So really trying to make sure that the data that was collected through those surveys was really meaningful and provided rich information for the clinician and research team. So that was really exciting. And some of the ideas around some of the research projects. So as a PACT group, we sit as part of our meetings and we share ideas around what types of projects would we like to see, what might be meaningful and impactful to families like myself, and how would we see participation from families as well, and how are we ensuring that we're reaching communities that may not have a voice in our projects and in our work. So it's really exciting, and it's empowering as a patient partner to be able to be involved in that work right from the very beginning. So it's very exciting and such a great opportunity and a welcome opportunity. Why did I choose to participate as a PAC member? As I mentioned, as a parent volunteer, as part of Target Kids PAC, I believe that the work that this group does, that the clinician team and the research team takes on, is invaluable. And I'm so grateful for the opportunity to participate, both as an advocate for children who aren't able to share their voice, and also for parents and caregivers who are invested in the health and well-being of their children, and understanding how meaningful these projects are to provide and shape the health care that's provided to these families. And as part of the benefits of my participation, I have a strong passion in advocating for patient involvement in work to support research and ensure that a patient's perspective is considered in all aspects of care. So being able to, what I call, humanize the data through collecting our stories and our shaping the work that's done through the patient's perspective and collected through the data collected through the Target Kids clinics and through research allows for the clinical and research teams to understand some of the unique challenges, some of the barriers and circumstances that families face that aren't always evident and available through the data that's collected. So really being able to bring our voice and help shape the types of research projects and the resources that are available, both to current families that participate in the Target Kids clinics, and also as we try to expand to other communities, the prospective families, while bringing diverse perspectives and experiences to the work, and really pushing for that equitable representation and inclusion across communities. So for me, it's been so empowering and so wonderful to see the work that's been happening through Target Kids and through the PACT and how it's evolved and grown over the years is My name is Maria, and I have been a member of the Target Kids. My name is Maria.
I'll just not cooperate.
My name is Maria.
Keep circling. So we're just gonna. She was at the end of her points anyway, and so apologize for the technical glitch. In echoing and hearing what Maria shared about the various ways that we've been involved, we also want to track and showcase the work that we've done. So just a snapshot of what we did in 2023, there were roughly 13 letters of support provided to different grant applications. There were 7 grant proposals and studies presented at the PACT meetings, and there was 4 projects where there were named parent advisors who stepped up to volunteer and follow through with different feedback and continued back and forth on different projects. So it's exciting to see the different ways that the PACT gets involved and our parents can get involved to inform our studies. We have a number of parent-involved publications where there are parents named as authors who took and parents who were involved in reviewing the manuscripts, reviewing the data, informing the analysis, and taking the research forward in a different way. We also highlighted what it was like to form our parent and clinician advisory in a healthy child cohort. Our priority setting exercise that we established, and family perspectives on COVID-19 research. The PACT helps us inform the research in various ways across our studies, and so are listed in the acknowledgements for our publications, but these are just several examples where the parents were involved in the writing, as those of you as trainees know the difference. When you're involved in the writing of the manuscript and you're taking it on from authorship level, it's a different way of bringing the parent voice and perspective to the academic settings. So how do we foster engagement and continued involvement from our PACT families? Here, Carrie, if this works.
As I reflect on being a PACT member, I can honestly say that the inclusivity and part of my identity of being a PACT member has grown. This PACT has allowed me to not only gain the inside track sort of knowledge about each research project being put forward, which is a really neat and cool thing to see for advancing children's health. But definitely there have been some friendships and partnerships that I've developed by being part of the PACT. This is a social group. There's lots of people with varying areas of interest and experiences. We all live in different areas of the city, and we actually do come together a few times a year, organized by the clinician team. And all the parents are welcome, and all of the research participants, being our children, are welcome too. So I grabbed onto that wholeheartedly from the beginning, because not only did I want to belong to helping research and understanding it for myself, but what an amazing opportunity to be able to bring my children who have been part of these studies and know that they're doing something great for research too, but they get to meet kids who do it too. And I get to meet the parents that I see at these meetings. So there have been numerous events over holidays in the summer and different things, and all of the kids now have asked for the parents' phone numbers. They want to go to Wonderland together. They know that these are their research partners, these kids in crime for research, and they feel a sense of pride, and they talk about it in school that they belong to research and they have a network and they have a group. And honestly, when I have questions about stuff going on with my own children, some of these parents have kids that are older and have gone through either research studies or different things. And I feel very open and comfortable to talk to them about it because of the welcoming and accepting nature of this group. So I feel very fortunate and very lucky to be a part of it. So do my kids. I definitely highly recommend it and enhance furthering all of this, I definitely think it's a good thing to join. As
So in addition to the work that we do technically and researchally and academic, and as academics, we seek their input to create opportunities for camaraderie. And we've done this in person and adapted in the pandemic. It didn't slow us down. We did virtual events where we mailed kids out, for example, and we did gingerbread house making when we couldn't gather in person. We've gathered in person in the summers and have played tag in the field together. I did a lot of rolling around that day. There were water balloons and whatever that was. We gathered at restaurants and the kids did crafts in the restaurant. While the parents could have an adult conversation, we had tables set up for crafting and in the early fall. We've done we've gathered here at the PGCRL and had a winter social where the parents got to not only meet each other, but also different members of the teams, different people, some trainees, some of our data analysts. We shared cake because that was promised and the kids made sure I got them cake. But we also have them help a little bit with our welcome packages, having them draw bags. So they're involved and invested in the process of what we're putting forward so other families can benefit from the work that we're doing too. And it's a wonderful community. So they get to feel the impact, the value of the research that's being put forward and the community that they can build together. So as I come to the last part of our section, the last part of my talk, it's really looking at the value of in-parent partnerships. So you'll hear from Carrie and you'll hear from Maureen. Welcome to go first if you like.
Sure. I mean, we kind of, can I go back to the other?
Yes.
It's
Yeah.
because,
Did you make notes of what you want to share?
well, my experience as a PACT member contributing to research.
Yeah.
Oh, it's coming like, wait a second. Okay. Okay, so the value in parent partnerships, say it's the same as the patient ones. There is something where not everybody in organization understands this. If you do any kind of business polling, sociological study stuff, you will discover, by the way, marketers are 100% way ahead of you on researching with children. And no offense, they do a better job. And they have scientists who are highly involved in this. Not necessarily medical, but one of the things I have noticed over the years is there's something like an insider versus an outsider status. I work very hard to cultivate the outsider status whenever I do something. Because the second you become an insider and every answer you give, somebody says, oh, this is stupid. This should be fixed. And there's patients say that kind of stuff all the time, right? And they'll say, well, that makes no sense. I don't understand. Why would you do this? The second you start answering with, yeah, we agree it's stupid, but you're an insider and you're giving an excuse for something that is anything from just annoying to completely unjust and inequitable and often unscientific. But for example, there are things like billing. How are things paid for? Why is it done this way versus that way? Not having an ultrasound in the ER so you can check something. Turns out that's actually not money, that's just a plain old bureaucratic fight over radiology versus ER and who's in charge and who gets to control that. Which is stupid. And I will keep saying that until I am 99 years old. I don't care about your fight. I care about finding out things like a diagnosis or, for example, one of the things I've gone through years and years and teaching, yes, even teaching med students about this, about how to deal with patients experiencing miscarriage, stillbirth, neonatal death, very sick kids. There's an awful lot of automatic self-blame in parents. It goes back like thousands of years to the ancient myth of the bad mother versus the good mother. And there was never an in-between. Anyway, it sort of transcended cultures, everything else. Well, the first thing is everybody has been socially trained to blame the mothers. And even if we don't want to, it's always the thing in the back of all of our heads, right? So that's the first thing that somebody's going to think about, and you have to be able to explain it in such a way that it isn't going to enhance the blame. Whatever it is. Oh, your kids got a speech delay. As much as I love that study, the reality of speech and language are different things. All my kids stuttered. The youngest one had a speech delay. That turned out to be due to needing ear tubes because his ears were totally blocked. We were able to use an iPad to teach language, and we took thousands of pictures and started typing like what it was, and it would read out the name, and we'd get him to trace it with his finger, and he'd see the pictures. So when he finally did start to speak at age 3, he could actually identify, giraffe, desk, TV, I don't know, like over and over again. Nobody told me that. Everybody just said, obviously, I was ignoring him. Also not great was the moment we were sitting there with the ENT at Sick Kids, and again, this guy's, I'm like, great, I know you're an expert in brain tumors of the ear and whatever, but just sort of, he hadn't opened the file, he hadn't even looked at our kid. He'd only seen the back of the head and he just met us. He said, not much you can do with these kids. Well, may as well just write them off. Which I actually got to know this guy, and I found out that he normally would never say this. It just happened he was in a particular mindset and just said it. And it by the way, is not true at all. It's not true about most of the patients and the kids and things you'll see. At least not true in the sense you can't always predict how things will go. But again, it's that we have to examine our own internal things, and patients can often tell us, wait a second, why are they reacting that way? Did I just say something that was invalidating? Did I just say something that was insulting? They don't even have to say it. Sometimes you just, oh, they're pulling back. Oh, they look shocked. There's a look on their face. Well, ask them if there's a problem, or ask the nurse if there's a problem. Honest to God, the nurse will tell you and know exactly what the hell the problem is. And if she doesn't actually work directly for you and depend on your paycheck, she'll tell you the truth. And yeah, take her advice. But it's the patient perspective in all areas can be valuable, as long as you don't feel offended, so offended you can't even question yourself. But what did I just do or say? So, there we go. Yes.
I believe that the PACT model is one of the prime and perhaps dare I say, one of the best ways to have a partnership for success in research in various forms, such as in recruitment for participants to maximize participation, to ensure equity and inclusion, and to ensure a very diverse range of opinions are considered for various topics in each research field. I really believe that the PACT model is one of strength. We have various people from numerous expertise in fields. They come to give training sessions and share all of their worldly and expertise knowledge within their professions. So we bring numerous people in from different areas to teach us, the parents, about what's actually happening and how with these different research topics and the whys behind it. So it really does help foster a very fulsome understanding of what goes behind research in these kind of fields. And of course, as a parent and with children, we belong to the Target Kids study, various studies. And so to be able to have an opinion and a say that is truly listened to and valued is one that just brings everybody together to enable such a solid work product and really deliver a successful outcome when it comes to research and bettering the health and wellness of all of the children. I believe
That comes to the end of our formal discussion and slides. And thank you for having us join you and look forward to having an open discussion. Priscilla?
Thank you so much, Danielle and Maureen, for sharing your perspectives and insights on, forming the Target Kids PACT group, how parents are being involved in the process of research from start to finish. And you're certainly seeing the fruit of all of this through the number of publications you've had, the fact that parents are being involved in these leading publications as well, and being able to produce outputs that are directly impacting children and families on the other end outside of academia. I know the booklet, for example, I had an opportunity to review it, and I think it's a wonderful, innovative output that other parents could benefit from seeing to acquaint themselves with the Target Kids program. So I'm going to open it up to those in the room and online to pose any questions you may have around forming advisory groups, given we have the opportunity to speak with the Target Kids group who have been doing this for quite some time and doing it very well with their existing PACT group. So for those online, please feel free to raise your virtual hands. I'll keep an eye on the chat as well. And for those in the room, please feel free to raise your actual hands. And we can go around the room and answer any questions you may have about the presentation, for instance. Yes, go ahead.
Hi. Thank you so much for the presentation. I just have two questions. So the first is, from your experience, what is the best way to approach the people that we think could be a part of the feedback committee? Like, let's say there's a physician hearing sick kids, is there patients? Is it good for the physician to just talk to patients and ask? Is it better for the research staff to reach out via email? And Maureen, thank you so much for sharing your experience. And my second question is, let's say we do that through email. What do you want to see in that email? Because I understand from your experience, you're a nutritionist, you talked to you in clinic. Let's say that didn't happen. She asked, she said, you just got an email from sick kids saying, oh, would you be interested to be part of the PPAC committee? What would you like to see in that?
Well, first, I would be astonished to get an email from a healthcare institution that didn't involve fundraising. I used to have a thing about this. I learned. I cold called the guy in charge of human ethics research and just started asking questions because something happened in the press. I had no clue who he was, right? Sat there for 2 hours on the phone and taught me all this. I look back, I'm like, why did he even? Anyway, there are good reasons for not approaching people through their own doctor or through email. But there's also good reasons to have them do it. Like saying to somebody, look, by the way, you know how you're wondering about what caused this to happen. Okay, we have these 2 or 3 research studies. If you feel like joining them, you can. Also, you can do something like, oh, I got an email actually from this about this. Specifically joining the PACT, the email was, okay, we're looking for people who want to join parent family training for family feedback. They just made it sound like it's sort of a committee in general, not anything specific to. And then what they did was they sent a survey. Well, of course, I didn't respond. I got like a cascade of emails. So they actually sent it out again, and it was not attached to fundraising. Because those, they get into my other boxes. Anyway, but the survey was good because it started talking about, are there things you're interested in? There are people who are far more interested not in doing research, giving you parent feedback, but they want to talk about things like the way your building is arranged and organized is terrible, and this is broken, and how do we get it fixed? And their whole thing is building, physical plant or something. There are other people who are more interested in communications in a clinic and between patients and things like that. Yeah, if you have a survey, you can start distilling what people want to do the most. That will help, because then you won't accidentally send somebody. It's also you have to make it reasonably short. If you send me a 28-pager, I'm not going to respond. Just to tell me how long it's going to be. But even if it's just a basic things, that helps. The other thing though is social media. It's very helpful to put things like this in some sort of symbol. Like too much text on the Instagram page is not good, because really I'm looking at it on here. And nobody's going on Instagram. Very few people on their giant laptop. But if it doesn't have too much text, I mean, social media is a great way to get the stuff out and have your institutions then have people share it to their group of people. Oh, we're looking for this.
Danielle, did you have anything to add?
Your considerations on how to approach your participants will determine on the relationship you already have in that population. So looking at, okay, you want to study X area, but you haven't worked with that population before, as Maureen highlighted, email will get lost. Like they won't recognize, they won't acknowledge, they won't know that this is something that they should pay attention to. The in-person, if feasible, allows you to build that rapport and helps you to kind of bridge some of that gap so that when an email is sent, they know to respond. So it's about understanding the familiarity you may have in that population. And if you're exploring something completely new, recognizing what that community may want or may need, which could be back in the days of paper and pen, it could be a letter, it could be a meeting, it could be something in person. Every group has different needs, and also understanding to bring forward someone who can identify with that population as well is very important. So that builds trust in whatever way you're making that approach. So if it's writing it in a language that makes sense, or having it shared in a language that makes sense, or infographics or pictorials, anything that makes sense to build that relationship and connection with the community is important.
I find it more impactful. For is that are like join previous studies, but they don't belong to some communities. Or is it just the same since the participant is just interested or just interested?
So for our particular cohort, we don't actually recruit as kids. So we're not in hospital, we're in clinic bases, we're in clinic practices across the community. So we're with family doctors and pediatricians for a better way to explain it. It all depends on what you want to follow and the data you can collect. Because you make a good point. You don't necessarily have to have someone continuously coming to a physical building if you're collecting data in a certain way. So it all it's not a direct answer. It just depends on the way that you framed your study and how you want to follow and pursue the collection of data. So if they don't have to come to a building and it's all survey based, great. But if there is blood draws or sample collection or x-rays or other things that are intervention based, then you have to think about what that looks like.
Not a problem. I was actually gonna put my 2 cents in as well. It sounds as though this is a project that you're working towards, and I'm not sure if it's been submitted to REB at this point for consideration in its design,
Yeah.
but it will be.
Yeah.
So a couple of things to consider are power imbalances. You had mentioned that potentially a doctor may be recruiting patients after seeing them during a visit and identifying that they need a set criteria that you would be looking for in terms of a patient recruited into this study. My concern around power imbalances is that a patient may feel that there are negative consequences associated with them not agreeing to be part of the particular study. So perhaps the physician themselves is the best person to be the one to do the ask. And for that reason, I often encourage teams to consider, I call them a point person on a research team who essentially will be there to do the invitation and to support families through the process where they can go to them with questions that they may have about the project, the documents they're receiving, a bit more with ease than a physician who we know often don't have the time to spend with participants to answer that level of detail in terms of questions. So I would consider that as part of your research design as you think through that element of your recruitment piece, because ethics may flag that also as a potential concern around risk. And
Just to add to that, because that is, I've heard that many times. MH actually begged research ethics to say they could have doctors and doctor assistants approach, put them in. And they did that specifically because the people they were getting did not have the specific kind of rare psychiatric illnesses. Nothing rare, but just certain illnesses. They just didn't have them, and nobody was volunteering, and they had nobody do it. And it wasn't a treatment study, so I guess they said it was okay, but it was, yeah, there are circumstances where what else are you going to do except have somebody directly approach? Because, I mean, you got all the healthy people in the world volunteering, they get volunteer hours.
I have a question online that I just wanted to raise for everyone. It reads, just to better understand, a parent participating to one study and refuses to participate to other studies, are they automatically a member of the PACT? And how many years or months is the membership of a parent when they become involved with the PACT?
So the first part is our parents are recruited into the parent advisory. So for context, Target Kids has a cohort of over 11,000 people, participants. Our PACT is not 11,000 parents, to address that first question. And if you're in one study and then not in others, that's not how we bring families into the parent advisory aspect, or how we have found parents who are wanting to be involved and engaged in the parent advisory. but also the limitations on if you choose to participate in one study that's been offered at Target Kids and not another, that's not a limitation. The participation is, are you part of the Target Kids longitudinal cohort? That's what we encourage. But we also have members of the PACT who aren't members of the study, but who are identified as people to give us another outside perspective and found out about our group. And we've welcomed in as additional voices, even though their children may not be registered in the PACT. In terms of the duration, we've been operating the PACT with a rotational membership. People joined at different time points. And we actually posed this to the parents to talk about the terms of reference so we could see what is the appetite and for the duration of involvement. What should be the exit strategy or graduation status, depending on the roles, the contribution, and giving that opportunity for parents to self-select as well. If they've been in for a year, 6 months, 10 years, what is your appetite for that? So we're actually still honing in on what those considerations are, but the feedback we received was partly to what Maureen alluded to on the insider versus outsider perspectives and evaluating a parent's contribution and viewpoints to ensure that they're continuing to engage in a critical fashion and not, as she denoted, the apathetic way of this is just the way it is, or this is why we've always done it. And it's a valuable insight and it's a valuable thing to consider because we can get complacent. And that's one of the things we don't want to happen with anyone involved in the research activities, but also the parents and families, because they might have been here for so long. We want to make sure that they continue to feel engaged and challenged and able to share perspectives that are intuitive and focused and reflective of the nature of what's going on.
Thank you so much for your responses. And for those on the line, thank you so much for posing that question. I see there's a follow-up question to that in the chat. What is the status now of the youth advisory group that Target Kids is planning to have?
We just got their name. I was so excited. I got it yesterday. So the youth advisory is currently underway. It was established in November is when they launched their training and they built their recruits, and they're continuing to meet and grow and develop the reviews for the tools that they were aiming to administer. So the team has a new name. I can get it for you. Give me a second. Quite clever. Very impressed. They've identified themselves as allies, adolescent-led initiative for exploring sexual health and screen use. Because we also, building on the naming, the nomenclature and the identity of the Parent and Clinician Team PACT, we challenge them as well to come up with what are we calling this group? What are you going to be looking at in this study, and how are we going to help support the identity of these youth co-researchers in Target Kids? So it's very exciting.
That's interesting. So, because I hadn't heard, so it's,
That just got yesterday.
but it's specifically on sexual health and screen use.
Yeah, that's what the study is. They're
So the
focusing
study,
on.
but there is an overall youth PACT.
We're hoping that it will translate to that. So this first group has been called together for this particular research study.
Interesting.
A question that I have for both of you, and something that may be on the minds of those in this room and on the call in terms of forming an advisory, is actually about a common challenge that researchers encounter when we talk about diverse representation. And you mentioned that in your presentation, that it's something you've bumped into in this process of forming the PACT. So I'm curious, from the Target Kids perspective, how do you approach equitable and diverse representation to ensure that you have those voices present at the table to inform the projects and priorities that you're pursuing?
I actually asked that of Carrie in advance. So she's got a response that we can share as well from a different parent perspective. And I welcome Maureen to dive in.
Interesting. Because the way I present or choose to present myself at this point in my life is completely put together. This hair is not cheap, people. okay? I put effort into this. But in cultivating the outsider status, let's be honest, I don't hang out with a very different crowd than when I was growing up. I'm a survivor of foster care, survivor of the adoption system, survivor of abuse, poverty, all sorts of things. I have ADHD. I have gone through all sorts of traumatic health experiences, and so I bring a lot of other things. I guess what I'm trying to say is you can't always tell by looking at someone exactly what parts they might fulfill. I mean, I've seen some people who you would never expect, who have very different points of view than you think. Also, it's also about how many people there are and patience, because I have been in a room and where they rank. Ministry was trying to do this huge consultation group review on a law that they had set up an act, and they had somehow managed to get like 35 people in the room, and I was the only patient. This did not produce a great. I was like deer in the head. They had a second patient. However, she was a nurse who had been like retired for many years. They had people of color who were all extremely low-ranked bureaucrats and who did not, I could just tell they didn't feel like they could say work. I ended up being the problem in the room. Because I was like, no. This committee was formed because of this reason, and none of you are taking into account race and racial characteristics. None of you are taking into account the incredible amount of misogyny and sexism and da. I was very gratified to see some people's faces like this was 16 through 15, which we weren't really talking, like it wasn't front and center. That said, of course, the report was written by two very kindly, well-meaning white male doctors who had wonderful backgrounds. God bless them. They lovely, they did it, but they weren't writing. They wrote a report that was kind of like considered radical because they were questioning whether or not certain things should be included. Like questioning, like, no. The other thing, by the way, all of you, please get to know how government works. We're in Ontario, we're in Canada. You need to know how governments decide things like everything, research grants to what gets funded. Because you're doing knowledge translation, you need to be able with knowledge to actually get it into the OHIP billing, hospital billing, or it's not going to happen. Or it has to be like one of the listed things that is recommended to save patients and teach patients. And it is so awful every time I see all these great studies and they just don't get into regular practice. And a lot of it's because the government hasn't said anything. Anyway, but yeah, reports like this, things that dramatically affect people's lives, they need to have, I would say, a larger proportion of patients, at least a quarter or a third, and you have to have sort of an even amount of power between people, like having bureaucrats there who are, they can't get fired, but they can get transferred to campus basing and whatever. I mean, their lives can be made very difficult, so that's not a fair way to diversity and representation on the committee. Also, nurses are generally seen as allies by patients. Because everybody knows they don't have as much power. So they have power in that they will back up patients. And that patients will see them as their friends and buddies. Not always, but sorry, I went.
Nope, okay.
Oh.
We have another question from someone online, which takes us back to the beginning of Target Kids, which I'm excited for. And you had mentioned in the presentation that Target Kids and the PACT really started at a time where there was little discussion around the importance and how to form patient advisory. So Target Kids kind of paved the way for some of the strategies of how to form these types of advisories. And the question is, taking you back in time, you know, how did you recruit parents and families from the start? What sort of strategies were you utilizing?
For my time.
Yeah.
But the way to recruit Target Kids' success was built on a model of in-person interaction, and that's how they also built the PACT. So Marie could tell you being approached by research assistants.
Yeah,
And
by Lori, who I knew by name well.
Yeah.
Because we had interacted often.
Carrie mentioned it in her summary that when she decided to join PACT, she was approached by her research assistant at her site. That's how we were able to identify the initial families who formed the PACT and grew the network. Some of the families who joined outside of Target Kids, they were connected by people who were in the PACT and having a conversation with someone else and like, I want to be involved in this. This sounds interesting. And they brought their names forward. So it was direct contact and word of mouth. We've since looked at highlighting that work more in creating posters that are put up in that can be put up in clinic to raise awareness as families are sitting there, maybe looking at their surveys and be like, I didn't know about this group, or how can I get involved? I had a research assistant tell me last month that a family reached out to them saying they're a new recruit and they're interested in being involved in the PACT. I'm like, great, get them on board. So it's really the initial way that we gain traction is word of mouth. But we talk a lot as a group about how can we enhance and increase representation. So it's not just talking to the families you might have built a rapport with, or you've established those comfortable connections, those very comfortable long-standing connections. But as Marie echoed, you know, you never know what someone looks like. You don't know what other pieces they may bring. So you don't know if this person is coming to this patient appointment and their child is spinning around, or they're exhausted, or they've been running late, if they could want to be involved in the PACT. And you might be very appreciative and respectful of the dynamics you're seeing and not mention something else, but they could be interested. So we want to create those opportunities in different ways and pathways for those parents to identify and come forward as well.
That's a great response. So what I'm gathering from that is, you know, having someone on site in the case of Target Kids who has really good rapport with the patients, has come to know them, who has built some level of trust, was the one initiating these conversations with potential future PACT members, which I think is a great tactic. You know, the first important piece of building out and forming a patient family or even community advisory is that building of trust, which we know takes time. So having someone existing within the space who can help leverage some of that and contribute to those conversations of how best to approach patients is really important when looking to form an advisory. I'm going to ask Pam, who's online with us, to unmute. She did have a question. Go ahead, Pam.
Hi, Pam.
Yes. Hi, Daniel. Thank you, Priscilla. Thank you for answering my question. Actually, honestly, the question was, although I did not intend to put you on spot, Danielle, for that question. I was I was going to ask Priscilla specifically for the youth advisory group because I'm one of the research assistants in Target Kids. So I am familiar in the approaching of parents who might be interested in PACT, and you can sense whenever you know the parent well, as what Daniel said, through communication and interaction with the parents, you will know and feel if they will fit for PACT and if they will be able to commit with the needs or expectations of PACT. But specifically, the question about the recruitment of the youth advisory group, because I wasn't involved at anything about that. So I was curious how they were able to recruit those participants for the youth advisory group. Thank you. Thank you, Priscilla.
Thank you. So we had a poster that was circulated to PACT members and in our newsletter as one other ways of disseminating that outreach. They had an active recruitment link because they had to interview and like get train and get people involved. So we tried to do some outreach from the Target Kids side directly on social media and other avenues. And then the researchers who are leading it, which are Dr. Ashley Vandermorris and Dr. Ellen Tulani, they disseminated it to their networks because they have an established connections to previous youth researchers using the YPAR methodology. So they have other platforms that they connected and cast the net. The objective is to get Target Kids eligible Target Kids youth as well involved in the advisory. I have not yet met them, so I'm excited to meet them. They when they connected in November, other team members went to their first training, and we're looking forward to seeing their work come to fruition.
What ages are they?
Was I have to go back and look. I don't actually.
Is it like teens or?
Yeah, the 15, 16-ish age.
Any other questions from those in the room related to their project? Perhaps anything related, oh, I missed you, sorry about that.
Sorry. Again, in Target Kids, you guys have an approach where you guys target clinics as opposed to hospitals or institutions. Is that specifically designed to target more representative samples? So again, less big hospital, primary care, tertiary care centers, and more focused on clinics just to get, again, the population that you're after.
Yeah, there's a short, yes is the short answer. Because hospitals often see patients who have different ailments, illnesses, and different needs, our aim is, as we coined it, simply a healthy child cohort. It doesn't mean that the children recruited don't have other considerations, but they aren't, for example, sick kids, sick patients. So we're not looking at the complex care or the high intervention, high needs children at this point. We're trying to develop a cohort as a well-valued comparable, because so that's why we went to clinic that practice network.
I will say that some of the family practices are associated with
Oh yes,
hospitals too. Like hospitals have family practice, but may not be located on the site, but are.
Yep. We have several St. Michael locations in different community settings.
That was actually an amazing thing. One of the other reasons I wanted to sign George up, because goal was healthy kids, and I believe the discussion at the time is, yeah, we only study sick kids. We don't have data on just bring average healthy kids longitudinally. Like, I don't think they had good blood test labs. Like, they sort of targeted and gone, okay, over this many people, but you don't necessarily know when you're doing a lab test on somebody, were they sick that day? Is this typical circumstances of events for you?
That's a really great question, and I'm going to segue back to you, Danielle, as to whether you want to mention community health center.
Oh yes, our expansion, our community for expansion. Yes, so we recognize there are gaps in representation because not everyone can access a pediatrician or a family health care center. So we're now in the position to start exploring other avenues for us to be accessing more diverse representation in patients and families who access healthcare in different models. So we're currently working actively with the Leon Center, being Priscilla, and others to work on a collaboration to explore expansion in community health centers as a different setting. We've done some work in the past with this model, but looking to do more intentional, long scale and widespread exploration of how that partnership and collaboration could work. And we're also open to looking at other models where the health dynamic is supported. So I don't want to say doctor patient, because it could be nurse practitioner, it could be it could be a rotational clinician, it could be different ways where the families are accessing healthcare in different settings. We're not there yet, but we're happy to be looking and exploring what those opportunities are.
Yeah, just following up on that, thank you very much for sharing that information. When you mentioned intentional kind of recruitment of these centers, would you ever consider intentional recruitment within the PACT itself, just to have parent representation, not just with the identity of a parent, but maybe a single parent, a parent from different ethnic backgrounds? Would you consider that as well, an intentional recruitment in that more individual specific aspect?
Yes, and it's something, the targeted recruitment and intentional recruitment has various considerations when it comes to equity, diversity, and inclusion, because there's always the concern of tokenism and there's always the concern of devaluing that person, the intentional aspect when recruited in a way that's not reflective of the buy-in you're hoping to gain, but also the representation of the demographics you're hoping to foster. So we are talking about what do we need, what data do we have on our parents to know, okay, well, what is the reflective representation of the population within Target Kids as well? Target Kids collects a robust wealth of data, as any parent can tell you, they've filled out a survey, that identifies information on sociodemographic, parent, household, stuff like those aspects that you're honing in on. So we are looking to make sure that we can represent all of our patients with also in the families that are joining and bringing those voices forward. But it's wonderful knowing that within our parent advisory, as we have, you met 3 mothers today, but we also have fathers who are part of our group. But we work really well to see how other perspectives are shared and shown as well. Trainee, do you want to add anything to this?
I know one of the things research is very sensitive to making sure they have Indigenous representation and how you approach people. It's great to do that, but one of the problems is, and I've discovered this, that people, they're almost afraid to ask anyone Indigenous in case they do it wrong. So I know that you guys are working on finding some people and figuring out ways to do this. There's part of me that's like, okay, but if you are so scared you're doing it wrong, then you just never do it. Not gonna work. Like anyway, there's good half, at least, Indigenous people live in urban centers. So it's quite likely not everybody identifies on all of the surveys. I don't know exactly the stuff you guys have in the
We collect that information. We know that we do have some Indigenous participants based on the data collected. For those who have, as you highlighted, chosen to identify on our survey, which is helpful.
Yeah.
So there is an intentionality because we've heard from the reason for at least our own approaches on intentional exploration for Indigenous growth and research is we've heard from Indigenous navigators the considerations we should be making on making these approaches and making sure that we're doing it cautiously and with a pragmatic and thoughtful approach to avoid tokenism, to avoid harm, to avoid feeling, to avoid creating more distance and disparity.
It is, and I absolutely get that. I just know that I actually have mentioned that we should include Indigenous participants in whatever this, I think the very first study application thing I did, and it's been at least 8 years. And I don't think anybody's done anything since, because again, it's like just to, I don't know why, but we can't let it go 8 years, pandemic or not, because we're afraid to get it wrong. At some point, that just leaves too many people out. I don't know. That's a bigger discussion in research, but I'm just saying there's a,
Really great question that you pose, and one that a lot of research teams are grappling with right now, because it's being asked more and more of us to make these considerations to ensure that our patient, family, and community advisories are representative of our communities that we're working with directly. And there's a lot of pre-engagement work that needs to go into planning for an advisory that often gets missed in the literature and in trainings that yourselves as trainees need to be considering as you're building out and forming your advisories, to really pose the question around what is the mutual beneficiality of including certain communities in this work? What are they getting out of it beyond, recognition in some capacity, improved health outcomes? Tangibly, what are they receiving outside of the academic world? They're not benefiting from our academic publications directly. They're not often invited to participate in conference presentations, though we're seeing more and more of that. But what can they tangibly take back to their communities and be able to share from these projects and research pieces that are beneficial to them? So again, a lot of pre-engagement planning goes into building out an equitable advisory, and it takes time. So often you start off with an initial group that can help inform the strategies moving forward to ensure that Indigenous voices, for instance, are at the table, but it takes a lot of strategizing and building of trust before that invitation can be sent out, so you can avoid tokenistic approaches and avoid doing harm, essentially.
is there a specific office or people who are employed with U of T research or the hospitals who somebody can go to?
There is actually. So this is a great question, Maureen. I'm so excited you brought this up. So myself is one of the resources that you can be tapping into. I offer a consultation service so we can continue these conversations specific to your research projects. The consultancy form is available on our Leong Center website that you complete, or you can feel free to send me a quick email and we can coordinate to meet, in the coming weeks to further have conversations. There's also Dr. Francine Buchanan, who offers, from the patient side of things, her own level of consultation, education, and training services. We are combining forces now, and we're developing an Office of Patient, Family, and Community Engagement here at SickKids, which will be an excellent resource for trainees like yourselves and researchers within the enterprise connected to U of T, who can tap into our resources, our family patient partners, and continue this growing discussion.
Specifically Indigenous?
Yeah.
Okay.
We're going to have Indigenous, we're going to have different community representations. Yes.
I just didn't know if it already existed or if it was.
It does not. We are building it out. There are pieces of that existing within the enterprise, but in silos. We're building something that unites all of these under a singular umbrella that our trainees and researchers can be accessing.
Because
we're definitely aware of the gaps. So that was the lead into this.
Yeah, it's again paying attention to politics and government help a lot in that area, because like I've gone to a bunch of different talks at Heart House and at other places where they have people coming in, like we did a whole thing on several different politicians and then mental health experts, and there was an Indigenous lead who was talking about how amazing. There are specific kinds of talk therapy in a lot of youth, and especially suicidal ones. So there was a whole thing about all these Indigenous kids. They were like flying them in to Toronto, bringing them there, and then they were there for weeks and months, which is really not great when you're trying to get them help in their community. I mean, obviously, not everybody's going to have a certain thing in every little village or on, but flying everybody to Toronto and leaving them there for months wasn't exactly an effective thing. But they were so scared. Oh my God, these kids are going to kill themselves. They just thought, oh, it's better to just remove them. This Indigenous lead, though, was saying that basically same kind of therapy involving, but a lot of validation of feelings, even if you can't validate the whatever circumstances. Like maybe their parent, maybe whatever. There are things you don't know if this particular event happened or not, but you can always validate somebody's feelings. Well, it turns out Indigenous people have been doing this for years and hundreds of years even. There's a whole thing about, comparing experiences of, yep, that happened. That was another colonial, whatever it was. And even long before this, they already knew how to do this, but nobody had actually checked and asked. And it was probably better if they had checked and asked, because then they could have done that kind of therapy or similar kinds of therapy up where the kids live. I'm sure that there was a whole budget thing. It was costing way too much, and never mind the damage, but it would have been cheaper to have therapists go up, consult, work on a program, and implement taking kids away. So that was definitely, I couldn't believe mine. This was the greatest idea ever. I'm supposed to just transport.
Absolutely, and we're seeing more and more of that, and that's why CIHR is pushing us to be very multidisciplinary with our teams to ensure that we have different perspectives at the table, not just in terms of researchers, but family, patient, community partners who are experts given their lived and living experience to help inform the shaping of these projects. So I just want to do a final sweep of those in the room as well as online to see if there are any additional questions that you might have for our presenters today. You're certainly welcome to continue the conversation offline with them. They're quite open to having emails sent to them, myself included. But just a final quick sweep to see if there's anything outstanding. I don't see anything. Oh, I see a comment from Pam that I'd like to mention to everyone. If you haven't had the opportunity to take the Stanyas Indigenous cultural safety training, it's one that certainly I would encourage you to take if you're planning to work with Indigenous communities. It gives you great insight into building relationships, how to navigate methodological approaches, and ensure that you're including 2IC in the design of your work, and of course encouraging you to engage with communities specifically through the course to ask questions you may have related to your projects. It was the Sanyas. I can send it to you. I can write it down actually before you. It's a fantastic course. SAN dash, yes, apostrophe YAS. Excellent. Many folks here at Sick Kids are encouraged to take it.
Oh, suddenly I thought of something. Things that are good for the PACT to have access to. Training stuff like this, if it's available, but also scientific studies back, like all this stuff is locked up. I hit paywalls constantly. I figured out how to get in through Toronto Public Library and various things, but it's impossible. So it makes it a lot easier if people, whether they're from minority groups or whatever group they're from, to know, oh, this is what's been done in the past, and you can read it. And by the way, a lot of us are very educated and can read studies and understand it. We may not understand each particular area of science, but for example, a lot of us know statistics and understand that part really easy, or there's sort of an assumption we wouldn't get it. Well, again,
You raised a really good point, Maureen, in that in supporting your parents and families as they are a part of your advisories. It's important that you ensure the documents you're sharing to everyone for an upcoming meeting, for instance, be accessible. That you're not simply just circulating a proposal that's really grounded in scientific evidence that not anyone can easily understand. Having that point person that I suggested at the beginning is incredibly, if you can afford it, of course, and build it into your project, a great resource to have, because they can often host one-on-ones or initial meetings prior to these bigger meetings to meet with families and have conversations around what to expect. Circulate pre-readings like the academic publications that you're mentioning that often would be beneficial for families and patients to read in advance of these larger meetings to ensure there are no paywalls, and brokering a bit of that relationship to ensure that when they do arrive at the table, they too are prepared to contribute beyond their lived and living experiences to the science. Well, if there aren't any additional questions from those in the room or online, I certainly want to thank Maureen and Danielle for joining us today. Please extend our appreciation to Carrie and Maria as well for sharing their voices through video. And for those who are interested in attend these trainee sessions, we will be hosting another one mid-March. I'll certainly circulate that invitation, so stay tuned. Thank you for joining, everyone, and please feel free to take some food on your way out. Thank you to the